Thanks to all of our witnesses. Obviously, exceptionally important topic to be able to talk through what we're going to do on drug pricing. This does affect a lot of people. I'm the primary caretaker for my mom who has Parkinson's and has exceptionally expensive medications, and continue to be able to monitor her medications and tracking this process with her. So all of us have stories of our families and what we're doing, and of individuals that are around us in the process on this. Schultz, Egan, I want to pick up on a conversation you had started a while ago on generics. And it's an issue that you and I have talked about before. In 2011, 71% of the generics were actually listed on the generic pricing tier. That was in 2011. Now in 2021, 10% of the generics are on the generic tier. So your comment was the way to solve some of this is to get more generics out there, more competition that drives the price down significantly. The problem with this is the drug companies and the pharmacy benefit managers are working together to be able to keep generics off the generic tier. So let me give you just two examples. The generic to Zygen, the acquisition cost for that generic is $45, but the price set by the PBM is $319. The copayment is $105 because it's not on the generic tier. Though it is a generic, it's not being listed on the generic tier. Another example is the generic to Gleevec. Acquisition cost $431 for the generic. It's very expensive. The PBM price for it, $4,620. The copay then is $1,521 because it's not on the generic tier. So that should be on the generic tier, but it's been negotiated by the PBMs and the drug companies not to be able to do this. This is an issue that is rapidly accelerated in the last 10 years, that generics don't end up on the generic tier. The consumer pays much more for that. How do we attack that?
So first, just to reiterate the importance of generic competition in the U.S., over 90% of scripts that get filled are generics.
Right.
And U.S. generics are cheaper than generics around the world. So we talk a lot about...
Not just 90% of the scripts that are filled are generics, but only 22% of the total cost for prescriptions are generic. So
I'm with you.
Overwhelmingly cheaper.
I'm with you on that.
Yeah.
Here's the issue. We all think that this is the result of the rebates from manufacturers to the PBMs for different tiers of placement. So my position as an economist is, look, pharmacy benefit managers must provide value. We know that managed care organizations provide value, and we hire them. An insurance plan might want to hire someone to manage the benefit, and they could pay them for that service. So the issue is the reimbursement through the manufacturer's rebates and or the DIR from the pharmacies. So we discussed for years in this town the notion of passing that rebate through to the ultimate purchaser at the point of sale. That means that co-insurance and out-of-pocket costs are driven off net prices, not list prices. Right. That takes away the tiered incentives that you're talking about. That would be one way to go. And my only caution is that given that there's a value there that has to be paid for it, it means that insurers will probably have to pay the PBMs, and it'll show up in premiums.
Yeah, but the challenge is if the larger drug companies are giving a benefit to the PBM to be able to say, if you'll put the generic competition on the higher price tier, then the consumer goes to the counter and says, hey, this is my script. Is there generic for this? And they say, yes, there is. It's the same price as the brand. And they'll say, okay, well, then just give me the brand, which drives out the generic from the market. Then the generic can't compete in that space, and eventually they drop out and stop producing it. We lose the benefit of it. If a generic is not put on a generic tier, they don't get the benefit of the lower price. If they get a benefit on that in their particular prescription plan, the consumer doesn't get it. The PBM gets the kickback on it coming from the pharmaceutical company saying, okay, thank you very much for helping us out on that, but the consumer doesn't see that.
And so passing it through the PBM to the consumer so that the PBM can't recoup anything from that rebate is one solution to that problem.
Be very, very significant. Dr. Conner, you wanted to say something on that?
I did. The problem with passing the rebate all the way through to consumers is that premiums are going to rise, and therefore disparities are going to grow. While I believe that there is cause for concern, particularly in the anti-competitive practices of the PBMs, we simply need more information. The story that you just told, that there are branded pharmaceutical companies that are placing their products on the lower tier than the generics, it may happen, but it appears to be rare. We need more information to understand exactly what is happening in this market. what are the benefits, what are the costs of the current configuration in order to move forward.
I would only say 10 years ago, 71% of the generics are on generic tiers. Now 10% are. There's definitely something happening in the last 10 years. And when Humira has generic competition starting next year, when there are 7 that are coming out on it, we'll all be watching very closely to see if those end up on generic tiers or if those end up on higher price tiers for the consumer.
Time of the gentleman's expired. Senator Carper.